Welcome back to PACHA's meeting. We are going to first consider a resolution concerning urgent action recommended for syphilis endemic. If staff can pull up, thank you. I'm not going to read the entire or even really read any of this, but what I want to do, especially for the folks who are in the audience here and online, just quickly outline what we have here. So in the first two whereases, we basically state that we've been meeting and we have heard a lot of concern, and in our own work, many of us are addressing syphilis and describing public health emergencies and declaring them. In the next 7 whereases, we provide data around the increase in syphilis cases. I'm especially concerned with primary and secondary cases, which are the most infectious, that this is happening all across the U.S. Discuss the impact here in gender, in racial and ethnic categories, in sexual behavior, and in particular congenital syphilis, which we heard the Admiral speak about. And just to put a point on that, in the last year, I think this is, 220 babies were born with congenital syphilis died. 200 of the, I forget, 2,855. So this is a severe disease. Then we talk about the shortage of bacillin and concern with the rescission in funds for disease intervention specialists in the debt bill that was passed, end of May. And then we go into the 3 resolves, which are the important actions that we are recommending to the Secretary. The first important action is that we are recommending that a federal task force be created to address this issue, that healthcare providers and the public be notified that we have an urgent issue, that there be full consideration given to declaring this a public health emergency, that work occurs with the Food and Drug Administration and the Administration for Strategic Preparedness and Response and manufacturers to address the shortage in the bacillin LA, and then to retain anything we can to retain the disease investigator workforce, since they really are part of on the front lines of helping us address this. So that is what is in this resolution. Carl has proposed a first whereas, which I mentioned to you to take a look at. And have we inserted, I'll just read that. The whereas addresses why PACHA would be considering this. And basically, we point out and have a reference that having syphilis can increase a person's risk for contracting HIV. And for those living with HIV, having syphilis may progress faster. Oh, do you have the written?
Is the first one?
Yeah. Okay, so I think it's, emailed. And then that it might be harder to treat. So we're proposing that go in the first. So I can reread it if you would like. Okay. Okay. And then Leo's going to have an edit to that. I know if you have other edits that you would like to see, would you please put up your card? I know Laura shared some good edits with me. Kay will give a chance to get, okay, that's popped in there the way it looks. Perfect. And just so you know, the HT in the final version, that'll be the reference, though that'll go at the bottom on the last line there. Okay, let me go to Laura.
Thank you. I suggest adding at the end of 11, after the word response, and in partnership with tribes and tribal organizations.
Hey, Laura, can I just confirm, is that 11 on there or is that 11 up on there now?
Oh, sorry.
Yeah.
Let's see it's
15.
15.
Yep. So
Can
line, now
Can I
line
take
15.
some of my edits to proposed, or do I need to talk about them first?
We should,
first?
yeah,
Okay.
yes.
Okay. Sorry. So let's see. Yeah, at the end of
Line 15.
line 15, sorry. And in partnership, they're going to type that. With tribes and tribal organizations. Okay. And then on the second page of the resolution, so in the resolve clauses, at number 1, the end of that line, after the word stakeholders, line 67, add and tribal nations in capitals. And then add a new number 2 after that. Conduct. Tribal consultation policy, all caps. Which is required before, quote, any action is taken that will significantly impact Indian capital tribes, capital, period, quote, end quote.
Fantastic. Thanks for those. And then on line 67, the and should be and. On line 67. Yep. Thank you. Vincent. I'm not going in any particular order at the moment because I didn't see, so we'll just go. All right.
So I have just more of a question, and then I may have a recommendation based on the answer. So this is for the group that worked on crafting this. I don't see in here any reference to a sort of targeted use of doxypap for incident syphilis. And so is that something that we should consider as at least something that should be explored, particularly for, MSM? So I'm curious about that. If so, I would advocate that we consider that.
You want to respond to that? Or who wants to respond?
Part of the sentence that talked about other alternatives would particularly include that, as well as consideration of, the other bacillin CR, which is at a lower dose. And, so not really getting into a lot of details, but using the general framework as alternative recommendations. Hopefully that answers it.
I guess just as a follow-up, I certainly appreciate that. And I wonder, Ada and others, if that's enough, or should we be thinking about this as a tool? It is a tool that I think we're using, and it's certainly one that is sort of at our disposal. And so I guess it was an unfortunate missed opportunity to not identify in some way.
So if you want to think of some language quickly, then we'll come back to you. Okay. Does that work?
I got it.
Oh, you have the language. Oh, great.
Yeah, it was just, I don't know if it's good language. I may need help from Ada and others, but.
And can you identify
so I think
in the
therefore.
So yeah, can you identify about?
Sure. So bullet point number 6.
So we're going to add a bullet 6. Right.
Yeah. So I guess I would add to further explore the targeted use of doxypap as a strategy to prevent incident syphilis cases.
Yep.
To further explore the targeted use of doxypap as a strategy to prevent incident syphilis cases.
Doxy prep.
Yeah.
We should spell it out.
Yeah.
Doxycycline.
Yeah.
Post-exposure
prophylaxis.
Doxycycline. Post-exposure prophylaxis.
And then continue. There's more. Is there more? Is that
as a strategy to prevent incident syphilis cases?
Right.
Incident.
Great. Thank you. Leo?
We can go back up to the first whereas. I'm recommending changing the word contracting to acquiring.
Okay. The risk of acquiring first, line 7. Instead of contracting, acquiring. Yep. Thank you. Ada? You're good? Okay. Mark?
In the first and number 1 under the therefore be it resolved as section, we say inclusive of community stakeholders, but I think the speaker yesterday referenced the success of monkeypox. And I think a lot of that success I saw firsthand in community-based organizations getting out in front and actually getting out of the gate faster. And so I think we should specifically reference the community-based organizations.
So
as opposed to stakeholders. It's more,
so it's inclusive of community-based organizations and get rid of stakeholders?
For me, it's more direct. I mean, if you understand the reference, I know I didn't want to put all the other piece in there, but again, the way that they were out of the gate and engaging the community around monkeypox, we need people out of the gate, on the ground, in the community, and that's the community-based organizations. So I think if we put that word in for me, that would hopefully communicate that.
Great. Leo, did you have anything else? Kay.
Sure. If you'll go down, maybe around 52 or 53 now, we're talking about FDA. Where is the FDA?
So line.
So where is it now? Yes. Okay. So at line 53, more clarity around Q2, because I don't know what Q2.
Oh, quarter 2.
I know what quarter 2 is, but it doesn't tell me when. Like, I don't know the quarters that, so I think just, by certain. Is it July?
I don't know. That's that was in the reference. I assumed it was.
So I don't know when this quarter. So I just think for clarity purposes and plain language, are we talking August? Are we talking July? I don't know. I think we just need to have the answer. Or
let's spell out quarter 2, and then after, assuming we're going to approve this, we can see if we can identify if they're indicating when. I assumed it was calendar year.
Well, then that's past then. Yeah. If you're talking about a calendar year of 23.
I mean, I think actually this came out June 12th. I suspect they were saying by the end of the month.
By the end of June.
Is my guess. But
right. Yeah.
Yeah.
That's it.
Okay. Laura, we got all yours. Any other I'll first start, any other suggested edits from PACHA council members, and checking online as well to make sure that any of you online PACHA members, if you have any input. Okay, then going to our federal partners, anything you would like to raise? Okay, I'll come back to Justin. Go ahead. Yes.
I was looking at the piece for quarter 2. Instead, we could change it to, because it has more of a statement. It talks about estimated recovery in 2024. But I will dig deeper into the quarter 2 piece for you.
That was on the FDA one, right?
Correct. And I can get you references and everything.
Okay. Great. Thank you. Justin?
So this is just a slight amendment to the first number 1. Just adding community-based organization. And I would actually say community-based organizations and other community stakeholders. And we just need to make, in tribal nations, to fix the grammar so that it's right.
Okay, we can fix grammar later. We know what we're saying now. That's good. Okay. Great. Any other edits? Oh, yes, go ahead. Thank you.
Is this on? Hello? Can you hear me? I was going to suggest, hold on.
And if you can speak directly into the mic, I know it's kind of hard, computer and all.
I wanted to ensure that reference to the association with substance use disorder, especially among congenital syphilis, was included. No?
So say it again.
I don't have a suggested wording. I apologize. I didn't prepare something ahead of time.
So the issue is with congenital syphilis.
Or the association with substance use disorder among, in relation to specifically like pregnant, postpartum, or pregnant women. No?
I'm not sure it's a no. I think we're trying to make sure we understand exactly where in the document you're interested in having us think about this. So it's with congenital syphilis.
Hold on 1 sec.
Okay, we'll come back to you. All right, yep. Rick?
So I'm just wondering if we should put a language in there, something about outbreak threshold or something about an alert threshold. Like, why are we doing this now? Are we talking about it? We've surpassed a threshold. For example, line, if you go back to the very first paragraph, was not line 10 before. Okay, line 14 after the word congenital syphilis, you could just put comma, surpassing outbreak threshold, comma.
My guess is I don't know that we have the exact data. My guess is maybe we've already done it, passed it as well. I think we would want to make sure we have a reference for that, and at the moment we don't.
Okay.
Unless somebody who's been working on this knows for sure.
Well, the only concern I would have with that is then you're restricting the particular ask for the federal task force to only focus on the outbreak places. So I would suggest to keep it out. And then as outbreaks happen, we can take a look at it in terms of the federal task force. Leave it up to them.
Okay. Are you good with that, Rick?
Yep.
Okay. Yes.
Yes. Towards the end of the document, under recommendations, the first and second ones, just an editorial consideration. We have the word establish with haste, and the second one, notify with haste. I was just wondering, it seemed a little bit of a older English word, if we had other alternatives for that.
With urgency? Would with urgency work?
Yeah, that would be good.
Great. Kristen, any?
I was looking for a place in the document that I would recommend it, and I haven't formulated that yet. So I'll shoot you an email if something comes to me.
All right. We're also, I think one of the things here, we're not actually trying to get perfect at the moment. We're trying to get enough to basically say, we've got to do these things. And so the particular things to, I think, make sure we're comfortable with is that the therefores are the items that we really want to put forward. Caroline.
I don't know if you can see, Laura, if your tent's still up or if you had a comment. I just want to make sure it's addressed. Okay, thanks.
And just one last for PACHA members or federal partners who are online, I want to make sure that if you have any issue or concern that we hear that. None online, great. PACHA Council members, so to just a quick, any conversation that anybody needs to have in order to feel comfortable voting on this. Can someone just in the hallway pull Carl in for the vote? Caroline, thanks. All right. I think we got a couple people going now. I think you're good.
And while we wait, John, the piece for the depletion for the FDA, it's already done. And all they talk about is the estimated recovery in 2024.
Okay. So it already has been depleted.
Correct.
Okay. So maybe, and the estimated recovery is
2024. So similar to the adult and the pediatric as well. Same thing.
Okay.
So John, just one thing, I don't want to hold us up. I just want to come back, Kristen, to your comment, because I believe that you were trying to articulate that somehow we should be engaging substance use
Yes.
prevention and treatment providers in increasing their screening efforts.
Thank you.
And so I feel like that should be there's a missing piece here, right?
I do think there's a missing piece there. I hadn't formulated it yet because I've been working on.
So can we add under, let's see, the one where we talk about, that one, notify with urgency healthcare providers, substance use care providers, and the public.
That's on line 72.
Yeah, yes.
Yeah, that takes care of my concern.
Perfect. Great. Vincent, thanks for hearing it because I wasn't quite hearing what I needed to hear.
Thank you. I like that. No, I was like skimming through trying to figure out where to put it, but I hadn't found it yet.
Thank you. I appreciate your persistence. Okay. Ada?
In that vein, I think that one of the whereas clauses should incorporate the connection with substance use, i.e. the increase in meth use in women, or, that's not stated in any of the whereas clauses, which will actually connect to that resolve clause. So if I don't know how quickly we can work on that.
If folks are comfortable, there is, can you guys pull up in the document? There is a whereas we can add quickly, I think, in your data.
From that paper, you want me to pull something? Okay. Can you give me a couple of minutes to just pull?
Actually, can we pass this knowing we will insert a whereas that describes the data related to this? We have it. Okay. So a little trust there. The good point that fits. Okay. Any other discussion before folks are comfortable moving to pass? Okay. Is somebody willing to move that PACHA pass this resolution? Ada moves. Do I have a second?
Second.
Second all the way around. John, yours came loud over the microphone, so I'm going to give it to you. To make sure I'm following procedure. Any further discussion? And all those in favor say aye.
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 All those opposed, same sign. Any abstention, same sign. Great. Thank you very much. Appreciate it, everyone. All right. Good, quick work based on what we've been hearing and seeing. By the way, if anybody, I shouldn't show it. If anybody's missing a bracelet, you might want to identify what it looks like because we have a bracelet up here. I know. Nobody claimed the phone. I don't know whose phone it is. All right. With that, I appreciate the patience of our guests in allowing us to take care of this while we had a quorum. That was important for us to do. So John Shapiro, turning it back over to you on community efforts to address the HIV epidemic in Arizona.
Thank you. Could I just ask, what is our new end time?
Can we postpone? So we were going to give you at least 15 more minutes. We took out more than that. Can we aim for 1-ish and see where we are? Is that respectful enough? Or
that works fantastic. Thank you so much.
Thanks.
And it was my phone, so thank you very much. Yes, and I will forego my comedy shtick in the interest of time, and I'll introduce some great people that are sitting before you today. So in our earlier session, we met 3 people who are working to end our HIV epidemic at the state and county levels. And now we will meet and hear about the great work that folks are doing at the community level and the city level to end our local HIV epidemic. Their bios are in tab, I believe, tab 4 of our binder. If you have a binder, So you can take a look at those to get a little bit more knowledge of who they are and why they're sitting at the table today. But I'm going to introduce to you Grace Ashu, the regional director from CAN Community Health. She will be followed by Duvia Lozano, the program director for Chicanos por la Causa. Sheila Soto, Director of Community Engagement and Outreach at the Mel and Enid Zuckerman College of Public Health at the University of Arizona. And then Tennis Vanek, the board member of the City of Phoenix Fast Track Cities Ad Hoc Committee and a local HIV physician who has local, national, and international renown for the work that he's doing. Grace, why don't we start off with CAN Community Health and your work?
Of course. I hope everybody can hear me. My name is Grace Ashu. I am the Regional Director of Prevention. I oversee Arizona, Texas, and South Carolina. And I would just like to say I am very excited to be here today. And I saw Miss Stewart just gave me a thumbs up because I heard that she was from Columbia, and we're actually based in Columbia for CAN. I would just like to say that there's so many inspiring leaders here, and just looking around the room, I'm so excited to be here and very thankful for this opportunity. And with that being said, I also wanted to kind of just give everybody a food for thought after what Leo shared. And a little bit of a question that I wrote down is, how do we begin to build more local programs that bring services directly to communities of color? And as a regional director, you all know that we see that the face of HIV is changing when it comes to data trends and the amount of individuals that are being diagnosed at high rates. It is in particular to Black heterosexual women. So with my position at CAN, I really wanted to begin my position with addressing how do we reach communities of color? How do we begin to address stigma when it comes to communities of color? And with that being said, it's not enough just to test at times. We have to be able to provide education. We have to be able to empower our communities, and we have to build new prevention interventions to be able to create more initiatives that center around that. So with that being said, I just wanted to recognize a few organizations alongside of me that do tremendous work when it comes to communities of color, one being Ebony House. Miss Angelica is in the crowd today, and then also looking to my left-hand side with Duvia, who's a part of Chicanos por la Causa. So very excited to be here again. And just to kind of start off before I go into my presentation, as I said, we are in areas that are very rural predominantly. Here in Arizona, we are based in Central Phoenix. However, when we reach outside of that for the areas that I serve, we're actually based in Arlington, Texas, which is right in between the Dallas-Fort Worth area. So with CAN, our overall mission is to go into areas where services are low. So with being said, that Arlington is an area that has very low services when it comes to HIV testing, STI testing, and Hep C testing. And we're also based in Columbia as well, which does see a lot of prevalence when it comes to HIV. However, there is a lack of service. So a lot of the ideas that I had that I brought to CAN over the past year is championing a community health initiative. And with that initiative, it's focusing mostly on communities of color and how we target the African American community, how we target the Native American community, and also how we target the Hispanic and Latino community. And in my presentation today, I am going to highlight the services that we offer in particular to the Native community. And with that being said, I also want to highlight one of our very special staff members that is not here today. She is from Navajo Nation. Her name is Allison Shirley, and she's done tremendous work in building the programs that we have in particular to the Native community. All right, thank you. Next slide, please. Just going to grab one. So the overall mission of CAN is to provide a continuum of medical, social, and education services essential to the health and well-being of those living with HIV, hepatitis C, and sexually transmitted diseases. And we do that in order to enhance public awareness. Next slide. With that being said, our overall vision is to serve humanity as the leading resource for education, prevention, and quality care. And we are actually not just based in Arizona, Texas, and South Carolina. We actually have multiple clinics expanding from West Coast to East Coast. So we're actually in Florida, Virginia, New Jersey, and then we're hoping to expand into Las Vegas soon, just based on the demographic and the need there as well. Next slide. Guiding principles. I won't go in particular to each one and talk you guys through that, but just wanted to highlight that CAN does operate within a very strict mission to be able to serve vulnerable and at-risk communities. So these are guiding principles that you see. We hope to communicate, advocate, research and innovate, execute, and sustain. Next slide. So overall scope of services. So I oversee our prevention department. And with that being said, we do testing. And when it comes to testing, CAN has a very particular initiative where we go out to local and rural counties all the way through Arizona and across our other states that I oversee to be able to offer free rapid HIV testing, Hep C testing, as well as chlamydia, gonorrhea, and syphilis testing, all aboard a mobile unit that's about the size of an Amazon Sprinter van. In that van, I will kind of walk you guys through what that looks like on the inside. You'll get a picture of what it looks like on the outside, but we are fully equipped to be able to provide rapid access care when it comes to HIV rapid treatment, as well as PrEP service care treatment and rapid engagement into PrEP. So a lot of our scope, in particular, when it comes to just testing, is also the scope of education. While we are able to go out to the local and rural communities, we want to make sure that we're not just testing, but we're talking to clients about education. One thing that I do want to say is when we go out to rural counties, we're in particular one of the only programs that go out to rural counties in Arizona to be able to offer the free testing. And with that being said, all of the clients that we do interact with at times, this is the only opportunity that they have to get tested, especially when we go out to areas like Maricopa County, further out inside the outskirts of Maricopa County, Tuba City, et cetera, kind of running down those local and rural counties. But these are their first opportunities to actually get tested. So with that being said, in our outreach, that's what we do to bring out our mobile unit. And we also have a clinical aspect. So we do have a brick and mortar clinic that is able to do clinical services such as medical, PrEP, treatment services. So as you guys see, our other scopes of services include case management and coordination, medical and dental care, and pharmaceutical services. And with that being said, we are able to deliver pharmaceutical drugs to individuals as soon as they need it through our mail ordering system. Next slide. So prevention services in Arizona, as I just described, we have a mobile health unit, which you guys will see a picture of it in the next slide. One of the other facets that we have for our prevention department is to do community engagement. So as we go out to be able to test, we want to build partnerships with community stakeholders to be able to say, not only are we trying to reach the community, we're trying to build rapport in the community and support the community. So with that being said, we are creating referral sources with different organizations. We are partnering when it comes to collaboration. We are helping them build programs that they have to sustain the communities that they serve. And then we're also making sure that we are not just taking away services from the community just by our services, but we're bringing more and we're creating a bridge to bridge that gap. So that's very important to us when it comes to community engagement. And then PrEP services with our prevention department, we are very focused on being able to talk about PrEP. As you may know, most individuals do have a specific face that they see when it comes to PrEP. So we're trying to change that narrative to be able to let people know, regardless of sexual orientation and gender, PrEP is for everybody. And with telehealth services, that is actually an area of growth that we've had in the past year. We're able now to say that we have a provider who serves multiple states across our regions that's able to take multiple individuals, engage them into care very quickly through our telehealth services. And aboard our mobile unit, we also have capacity via telehealth through 2 TV screens equipped in the mobile unit to serve the community to be able to engage them into rapid care. Next slide. So this is our mobile unit. It goes across our local and rural counties here in Arizona. All of our regions do have a mobile unit, and in that mobile unit, we regularly equip prevention specialists that are able to do the job of going out and testing. And as you guys see, we offer free rapid HIV testing, rapid Hep C testing, syphilis, chlamydia, and gonorrhea testing. And outreach to both local and rural areas for testing and education services is our main caveat of our scope. When it comes to serving serving the community, on average, we do about 15 outreach events per month in order to make sure that we're not only serving the community within regular business hours, we are out late nights, we are out early mornings, and we are also out during the weekends to be able to capture all clients throughout any facet of life or life events. When it comes to specifically talking about the Native American community, you'll see in the next few slides, we'll talk a little bit more about the partnerships that we've created, in particular with CAN and being able to start growing our partnerships in the Native community. As you all know, Arizona is a very sacred land when it comes to the Native community, and being able to honor that and bring more testing services and education is very important for us. As you know, we've recognized the gaps when it comes to HIV, Hep C. How we are able to provide support is our main caveat. So we are working with multiple agencies through Native Health, through other Native-based organizations to be able to provide support. So on average, we've been able to build multiple partnerships, which I will talk about, but we do test at different organizations that are Native focused or Native led. We have about 3 Native American events per month. Next slide. Community engagement, specifically focusing on our Native partners, we have been able to establish just kind of a startup partnership with the Intertribal Council of Arizona. We've had a few discussions. Maria Dygard, I know she presented yesterday with a wonderful job, and I know that I was able to kind of listen on the sessions today, or yesterday, excuse me, and they were wonderful, especially the male who spoke about the services in Chinle as well. That was very emotional and empowering, and it was very exciting to see the work that was done. We are also partnering with Phoenix Indian Center to be able to provide educational events, Tuba City Regional Healthcare to be able to establish a referral system, Winslow Indian Healthcare to be able to provide more education and testing, Navajo Nation Infectious Disease Control and Prevention Program to be able to start sending out home test kits. We've been able to provide them with about 20. We're hoping to expand the partnership to continuously providing them home test kits. So we are trying to find the gaps in these within the organizations and figure out how best we can work well together and collaborate. And these are the wonderful partnerships that we've established so far. Next slide. PrEP services, just to give you guys an overall schematic of how our PrEP services work at CAN, we want to be able to engage individuals as soon as possible. So when a client is receiving HIV testing among our mobile unit, we want to be able to also provide them with PrEP education. And then from that leads into promotion of PrEP services, counseling and education, and then we're able to link them as rapidly as we can to a provider who can be able to dispense PrEP to them, whether it's through sample packs, whether it's through a full prescription. We want to be able to engage that client once they're there. What we've noticed so far with our demographic is it's very transient at times based on our different regions. So we do want to be able to engage that individual as best as we can. Next slide. Telehealth services. As I've said, we do have rapid access to our telehealth services, which allows for CAN providers to meet clients where they're at. So our telehealth services occur via our mobile unit testing services. So on board of our mobile unit with our 2 television screens that are equipped to do that. And then also Rapid Start connection to care services. We are a part of the Rapid Start curriculum that's based here in Phoenix, where we're able to engage clients within care through referrals through our Maricopa County Health Department within 24 to 72 hours. And with that being said, I used to work at the Maricopa County Public Health Department. And with the work that we did to establish within our health department scope was to be able for any client that came in and did have a reactive test, we were able to link them to our in-house pharmacy to get them started with HIV medication. And that system still occurs today through Maricopa County. So it was very exciting to be a part of that program. And then also the wonderful work that Dr. Banning has done to establish that program throughout the entire ASO network has been wonderful as well. Next slide. Collaboration opportunities. We do have a very in-depth process when it comes to our community engagement department. Our Vice President of Community Engagement, Shannon DePalmo, is a very instrumental piece to the upbringing of Arizona and our partnerships here. And with that being said, we also want to make sure that when we go out, we talk to our community partners that we're establishing that we want to support them, whether it's through bilateral referral source, event-based collaborations, recurrent testing events via mobile unit or within partner facilities, through home test kits, educational sessions, and also providing educational materials as well. Next slide. bilateral, referral source, and event-based collaborations, just to kind of give you guys a little bit more perspective on what we do when it comes to the Native organizations that we work with, specifically event-based with the Indian Center. We've been able to take part most recently in the Two-Spirit Powwow, Navajo Nation Pride, Navajo Nation Fairs. That is when we're able to bring out our mobile unit. And then when it comes to bilateral references, we're able to refer individuals that we do test back to communities where they feel comfortable or back to organizations where they feel comfortable. So we've been able to establish bilateral references to Tuba City Regional Healthcare, Navajo Nation Infectious Disease Program, and then also, as I've said, provide more educational opportunities for other centers that want to learn more about HIV, STIs, and hepatitis C, and that is through Winslow Indian Healthcare. Next slide. Recurrent testing event opportunities are very big for us, especially with our mobile unit operations. So being able to prioritize long-term connections that we've made at Native-led behavioral health centers is very important, as at times testing isn't always readily available when in need, especially when it comes to syphilis and hepatitis C. So we've been able to partner with Desert Sage Behavioral Health Center and Blue Sage Behavioral Health for over a year, and we actually go out to those centers biweekly, monthly, or quarterly, depending on the partnership, to be able to offer testing. Next slide. Home test kits and educational session materials. We always want to be able to equip the partners that we work with the amount of educational materials or home test kits or other supplies necessary. So our most recent partnership with Navajo Nation has been a wonderful partnership where we've been able to establish multiple home test kits to be sent out every so often to be able to provide to the community. As you all may know, at times, delivering home test kits to the reservation is not readily available based on PO box differences and not being able to deliver those through a mailing system. So being able to provide the Navajo Nation Infectious Disease Program with home test kits allows more opportunity for the community to access testing. Next slide. What's next? So when it comes to CAN, we want to expand our network and create more collaboration opportunities. And in general, just working with our organizations and different partners, we always ask, how can we work together to bridge the gaps and ensure the community has services and resources it needs? And when it comes to other communities of color that we work with, most specifically African American or Hispanic Latino, we do have goals in order to ensure that we are meeting the community where they're at. So with that being said, with building out this initiative, I really wanted to focus on being able to create long-lasting partnerships and long-lasting support. I think trust is a huge factor when it comes to communities of color. So being able to continuously being seen and show up and support is a major factor. So with this initiative, we were able to secure funding from external funders that were able to provide us more information, more support, and also more financial support for these organizations that are doing the work in their communities. And that was through our pharmaceutical partners, Gilead and ViiV. So it was very exciting to be able to secure that and work alongside of wonderful community liaisons and other ViiV and other Gilead representatives, that were able to kind of give us more ideas on how we can create more impact. So we're looking forward to more facets into our community health initiative, more ideas, and then also hopeful for just building upon this program. Thank you.
Thank you so much, Grace. Next, we'll move to Duvia Lozano with Chicanos por la Casa. I'm so excited to see you here today. Thanks for coming.
Thank you, John. I appreciate the invite. It's so great to see everybody today and to meet all these wonderful new faces. My name is Duvia Lozano. I am the program director of Chicanos por la Causa Luces, which stands for Latinos Unidos contra el SIDA, or Latinos United Against HIV and AIDS program. I have been working for Chicanos por la Casa for 22 years now, 15 years leading the Latinos Unidos contra el SIDA program. It has grown significantly, so I'm very excited to share all of the wonderful things that we've done with this program to grow it and expand it to provide services for uninsured and underinsured communities. So there is a presentation, John. I don't know if we can put the slides up, if you don't mind.
I'll look to our tech folks or Carolyn. 30 seconds.
Great. So I will continue speaking in those 30 seconds if you don't mind. So our organization was founded in 1969 after the United...
Is this the right?
No, that is not the correct one, no. Ours does say Chicanos por la Causa on it. So our organization was founded in 1969 after the United Farm Worker Movement by Cesar Chavez. We do have 4 pillars of services, including integrated health and human services, economic development, social services and education, and finance pillar. Our Luces program falls under the integrated health and human services pillar. And we are a program with a mission of empowering the Latino community to live empowered lives. We like to be known as a light of hope in the community for these individuals. What else can I tell you about my program? There's so many slides, so I would really love it. Okay, perfect. Thank you, Carolyn. I appreciate it. I think it's a little bit more organized with the slides.
Okay, they just need to get them sent to the right people.
Yeah.
Yes.
There we go. Perfect. Thank you so much.
Thank you.
So we've listed here a couple of things on our menu of services. We do provide direct services in the community. Our HIV services department consists of medical case management, supportive case management, psychosocial support, our newly diagnosed university, which we like to call the Fuerza Positiva University, our mental health, and our substance use services. Under our prevention department, we do offer PrEP and PEP navigation, PrEP support groups, HIV testing, just recently added full panel STI testing, which we're really excited about because it's been going really well. And then our CPOC community events and our behavioral health intervention program. Next slide, please. In our medical case management department, I did want to have a slide that's different for every service that we provide, because our work is a little bit different because of the population that we work with. Typically at Chicanos por la Causa, anybody that is a consumer of medical case management services will initially, once they're initially diagnosed, will come into our medical case management services and work with a case manager until they have established a suppressed viral load. After a patient suppresses their viral load, then we can transfer them over to our supportive case management services. But under our medical case management model, this is where we utilize a rapid linkage to care. We are very fortunate to have an amazing team of individuals that can complete the rapid linkage of care process within 3 business days, which means that they've already seen their primary HIV doctor. They have completed the intake with Chicanos por la Causa, and they also have a prescription for medication. So that is amazing in itself. Next slide, please. Our supportive case management services are for individuals that are virally suppressed and have shown that they are able to sustain viral load suppression for 6 months or longer in our program. Typically, individuals stay in medical case management for at least a year before they are transferred over to our supportive case management services, where they continue to receive these amazing services that we provide, such as connection to community resources, help with their ADAP application and Riot and White applications. In our community, it is very essential that our individuals stay connected to a case manager because a lot of our clients do not speak English. So we do have to provide those services in Spanish to them. And I know that there's other organizations in Arizona that do the model where individuals can do like a self-care model where they do their own applications. But for us, it is essential that we revise those applications and we ensure that our people stay connected to care and that they're doing it right? That at least they get that support. Another thing that that I'm very proud of that we do at Chicanos por la Causa is that we do connect with our consumers on a monthly basis when they are in medical case management. Once they are in supportive care, we have a minimum of every 3 months connection. But that is never the case. The case is that we are always connected to them on a monthly basis because our clients are very comfortable talking to their case managers, and there is a great need in the community, so that communication is always ongoing. Next slide, please. Our psychosocial support services, we're really proud of this category. Funny story, we actually started Chicanos por la Causa Luces about 30 years ago. Our organization has been in existence for over 50 years. Over 30 years ago, a group in the community came together, a group of Latinos living with HIV. They were looking for a place where they could meet to get support from one another. A lot of organizations turned them away, but Chicanos por la Causa said, we will take you in and we will give you a space to meet. That was over 30 years ago. That is what started our program. We applied for a $5,000 grant for a support group. This support group has been in existence over 30 years in the community. Some of our clients have been participating in that support group for 30 years now. It is a Spanish-speaking support group every Wednesday night from 6 p.m. to 8 p.m., and it is very well attended. This week we had over 30 participants. It is growing and it is thriving, and it's something very much needed in our community. I believe at the current moment, it is the only Spanish-speaking group that happens late night every Wednesday. So that's a very well-established group. Since then, we have added different groups. We have our Fortaleza group. We have our Rising Above group. We have our Mujeres Poderosas group, which is a group that's specifically tailored for women. We have our transgender group. We have our New Perspectives group. So we have tailored different services that different people can take advantage of those. We do serve the Latino community, but we have people that we serve from so many different countries. It's not just people from Mexico. We have, immigrants from Guatemala, immigrants from Puerto Rico, immigrants from Cuba that we serve. Afro-Latinos, indigenous populations. So we're very excited that we have these support groups, because it is proven that individuals that attend support groups, based on our continuum of care data, we found out that 96% of the individuals that we're serving through these support groups sustain viral load suppression. And that is very important to us. So we are very fortunate that we have these services, that they're available to everybody in the community, and that we are receiving funding for them. Next slide, please. I'm going to talk a little bit more about our Fuerza Positiva University. We did not have this program. This is a brand new funding opportunity for us. We just gained this 2 years ago, and I am very happy to report that when we received the funding, we were challenged with developing a curriculum for the Fuerza Positiva University. It did not come with the curriculum. So myself and our program coordinator, Daniel Iniguez, and at that time, one of our facilitators, Alexia Macias, came together and we started developing a curriculum. The challenge for us was not only selecting the 12-week session curriculum and developing and creating the slides and creating the content, but also translating that to Spanish and developing tools such as the pre and post test, so that we can actually test that these curriculums are working. We're very proud to report that we had to move on that very quickly. It took us a year to develop the curriculum. It took us a couple months thereafter to translate everything into Spanish. We got our research and evaluation department involved. We're very lucky that we do have a research and evaluation department at Chicanos por la Causa that helped us develop our pre and post. And we are now offering that to the community. We are showing great success with the development of that. So we are very excited, and maybe in the future it can become, an evidence-based curriculum. So we are looking forward to continuing to gather the data of the consumers that are participating in this. This is a 12-week curriculum, like I mentioned before. There is a graduation at the end of the curriculum. We do invite individuals that are that have been living with HIV, that have success stories to share during their graduation, which is very empowering to the individuals that participate in these programs. Individuals are incentivized. Sessions can be during groups, sessions can be individual. So we do tailor it to whatever they need. We do provide transportation for individuals so that they can participate in these very important programs. And it has been a tremendous, tremendous success. People that are living with HIV for a very long time continue to tell us, I don't know why we didn't have these before. I wish I would have been able to participate in a program such as this. And the beauty of it is, once they're done with our Fuerza Positiva University, it is on the same day and it is at the same location where we host our other support groups. So people transition. They don't just end the Fuerza Positiva University. They continue to get that support through our other support groups. So they graduate into another group, right? That they can participate ongoing, indefinitely. Next slide, please. Our mental health and substance abuse services are funded through Ryan White. Ryan White is a payer of last resort, so we do have to assess individuals for insurance. But we are very fortunate that at the clinic where we are located, we are also co-located with a mental health, substance abuse, and children's services. So for individuals that do not qualify under the Ryan White services funding source, we are able to engage them in the same clinic at the same time that they are receiving their HIV services. So we're very fortunate. A lot of individuals do come to us with mental health issues and substance abuse issues that are a barrier to care for them. We do specialize in providing mental health services through group and individual sessions. We are also very fortunate to have a Chicanos por la Causa Substance Abuse Inpatient Treatment Center where we can refer these individuals and where we have funding for uninsured and underinsured patients. And the services are available in English and Spanish to them. So if we cannot find it at Luces, we will make sure that they are connected within our organization or within the community. Usually we can find it within our organization. CPLC, I don't think I mentioned this in the beginning, but we are located in 5 different states. Luces has programs here in Arizona. Arizona is our main hub, but we also have a Luces program in Las Vegas, which has just gotten started and it's thriving and it's doing really well. So we are able to, unite forces with other programs within our organization to get all of those community needs met. Next slide, please. HIV testing. HIV testing, we have a great story. HIV testing started in our service menu a couple years back. CPLC did not have any funding for HIV testing, but we were getting a lot of people in the community coming to our center to get tested. So we reached out to a partner organization, Aunt Rita's Foundation, and they offered us home HIV test kits. So that was our first baby step into, HIV testing. We learned how to do the home HIV testing. We were very fortunate to be able to attend the U.S. Conference on AIDS, where we met with people from the 4th generation allele testing. They said, we're going to come to Arizona. We're going to train you for free. And I said, wonderful, let's do this. We got everybody trained, even though our staff, we're pretty crazy like that. Even though our staff are on very many different contracts, they are always open to going above and beyond. And we cross-trained everybody in our staff to learn how to do the allele 4th generation testing. And our very first grant from the Arizona Department of Health Services happened several years ago. It was a $50,000 grant. So that got us our first tester. So we had a tester prep navigator combination. And since then, during the pandemic, believe it or not, our work, quadrupled. So we had to become very innovative and we didn't know what we were going to do because we weren't able to see people face to face. So what we decided to do, because something that was happening that was very successful for us, was our alliance with St. Mary's Food Bank. During the pandemic, people were losing their jobs. People were losing their homes. People had food insecurity. People were coming. We had a drive-through food pantry established for people to come and pick up food boxes. That became really popular. And sometimes we had up to 300 cars waiting in line to pick up food boxes. So we decided, you know what, we are going to do mobile testing. We started doing mobile testing. We had an area set up outside where people can just pick up their food box, pull over, get a quick finger stick. And that's how we did it, or pick up a home HIV test kit. We're really happy to report that we are the first program that ADHS has piloted in terms of follow-up after people receive home HIV test kits. What we were doing in Arizona before was handing over the HIV test kits, but then we weren't calling people for results, right? Now we're calling people and we're getting those results and we're getting the data that we need in our state. So lots of great things, lots of great partnerships. I also want to mention our partnership with mobile unit. CPLC does not have a mobile unit at this time, but that has never stopped us from providing mobile services in the community. Our team is highly mobile. I know that some programs don't understand sometimes, like, you guys have a clinic, like, why are you guys in the community? Our community doesn't work that way. The needs of our community are different. We have to come to people where they're at. There are trust factors sometimes with immigration that pose a barrier for people coming to care at our clinic. There are transportation barriers sometimes. So when people tell us, I need the service at my home, I need the service in my neighborhood, I need the service at my job, we will be there and we will meet you where you're at. So that goes for applications, that goes for testing, that goes for PrEP navigation. We are highly mobile in the community. One of the things that has been really positive for us has been the great success that we've had with developing community events. Community events for testing are these large scale events that we put together where we invite CAN, we invite Spectrum Medical to come, we invite Part A, we invite Part B, and everybody in the community. We try to normalize HIV testing, PrEP navigation, and access to services, right? There's so much stigma in the Latino community that these events have given us a window of opportunity to bring these to the community and normalize it. Grandma can attend, aunts and uncles can attend, your children can attend. It's a family-centered event that provides testing opportunities. We test for tacos, we test for different prizes. That works amazing. Our community loves to eat great food. So if you come to our testing event, you are going to get free tacos. You are, you're going to get incentivized. You're going to get a little wristband, and you're going to have access to these amazing things like COVID-19 testing. Actually, during the pandemic, we mimicked the city of Phoenix, and we were going to all of their COVID clinics with our testing people with tents and tables. So now I'm happy to report, we have great alliances with Kent Community Health that lets us borrow their van, with Spectrum Medical that lets us borrow their van, Ripple Phoenix. We cannot thank them enough for allowing our people, our staff to come and test along with you, because there is so much to cover in the community that we cannot do it alone. There is so much need, right? Next slide, please. STI testing, like I mentioned before, we just added STI testing. STI testing, we are not only doing at the clinic, but we are also doing out in the community. We have great partnerships with different police departments where we go test with them during their sting operations. That is very, that has resulted in really good results for us. So we are testing victims of human trafficking. We are testing sex workers as well. We've had a really high incidence in those communities of STIs, and we are getting them connected to care. We also are partnering with Chicanos por la Causa Parenting Arizona, because we are seeing the syphilis epidemic going on a rise. So we are creating an alliance with them so that we can get all of those moms tested when they're pregnant. We are also in alliance with our homeless shelter, Chicanos por la Causa de Colores, where we are going and we're offering these STI panels to these moms. So we are doing everything we can. Any alliance that people throw our way, we are si se puede. We are Chicanos por la Causa. Yes, we can, right? After the great Cesar Chavez. So we pretty much say yes to everything because we love the work that we do, and we're very passionate about bringing that to the community. Next slide, please. PrEP and PEP navigation. We do offer PrEP and PEP navigation as well. We have a great alliance with some of our community partners. We do not have at this moment in time, even though it is in the works already, to have medical providers at our site. We're already working on that. But for the time being, we have amazing partnerships with CAN Community Health, Spectrum Medical, Southwest Center for HIV, where our patients can access that care. We do have a 340B program that we offer also our patients living with HIV and our patients in PrEP and PEP navigation, which is a mail order program, so people can get their prescriptions at home in the comfort of their home, which is great. One of the things that continues to be a challenge for us in our 340B program is the fact that most of our people are undocumented or underinsured, which we know for those 340B programs to be successful, people have to have some type of insurance, right? The importance of the 340B program for us is that we have developed a rental assistance program out of that 340B, and that is just the need for individuals requesting rental assistance has just skyrocketed because of the housing situation crisis. There are so many barriers that we have to deal with on a daily basis. Unfortunately, for our uninsured, undocumented clients, there are so many barriers to accessing assistance for rent, right? Because there are documents that they have to provide that sometimes do not allow them to qualify for these programs. So we're very fortunate that at CPLC, we have this rental assistance through our 340B. We're trying to empower our clients by letting them know, if you participate in this, this is something that can give back to you at a moment of need, right? So if you have that need, it's a program that gives back to the community, definitely. Next slide, please. So this is a little bit about our food pantry initiative that I mentioned earlier, where we, are testing, where we are doing the mobile food pantry and also testing in the community. So I'm not going to spend a whole lot of time in that. Next slide, please. So our work with the Pascuayaqui tribe, I wanted to mention CPLC does have a clinic in Guadalupe, in the city of Guadalupe, that we partner with. Guadalupe is a town in Maricopa. It's part of the Phoenix metropolitan area. And this is where three cultures flourish. Nearly all the Yaqui people are U.S. born, the Yaqui people that we work in the city of Guadalupe. Their culture is rooted in Mexico, so they do speak Spanish, and they're predominantly Catholic. It took years for us. I cannot stress enough the importance of the alliance that we have with the Guadalupe Clinic and their staff members that have allowed us to come into that clinic and build that trust with the community. There's still a lot of stigma surrounding HIV with the Pascuayaqui tribe. Even a simple thing like accessing condoms was something that carries such a high stigma, right, in their community. We're very fortunate to say that not only are we started with the condom distribution, so people were very shy about it at the beginning, but it has since then morphed to there is a place now in that community where people can come and access HIV testing, STI testing, educational series that we can provide to them regarding HIV and PrEP and PEP navigation and all the wonderful services that we can provide for them, even education for their youth, right? Because it's important that the youth also get that education. So I listed a couple things that we're doing with the Pascuayaqui tribe. Next slide, please. Oh, and that's the end of my slides. But I also want to tell you a little bit about what we're doing with the Tohono, the Nahualin high school that we have in Tucson, Arizona. We are also providing services to the Nahualin tribe. The Nahualin tribe is also a Mexican-rooted tribal resource for LGBTQ plus youth that are attending high school. The high school is managed by Chicanos por la Causa. We are also very strongly connected to them, bringing resources to them through education, condom distribution, and testing. We are looking at piloting a program right now with our Chicanos por la Causa Yuma offices, where we are going to be coming in to serve the Cocopa reservation and also Mexican Americans that are living in Yuma. Yuma has a very high incidence of HIV. The resources are a lot less in that community. We're very fortunate that we have office space over there. We do not have the funding, but we are very well known for moving forward and finding the resources that we need to get these programs started and up and running. So that's what I love about our program, is that even though we do not let that stop us, we find a way to make things happen. And we're piloting that this year. Before the end of the year, we're going to pilot our services over there. There is great need. We have had clients in the past coming all the way from Yuma to access services with Chicanos por la Causa Luces here in Phoenix. So we did have a client that was making that trip on a monthly basis to come and get their medical care and their medication because they didn't have access to that in the Yuma area. So great work being done at Chicanos por la Causa. We are very blessed to be working with Ryan Perde, the Department of Health. I know during COVID, one of the big needs in our community was housing instability. People were losing their jobs left and right. We started tracking all of the patients that were losing their jobs. And once we got to 50, I said, we need to do something about this. This is like so many people losing their jobs and losing their homes, which means that they are, not going to pay attention to being virally suppressed and going to their doctor visits. One of the things that we did, we advocated, we sent an email out to the Department of Health. We sent an email out to Maricopa County, Ryan Perde, and we told them, here's the data. This is what's happening in our community. They turned around and they looked for funding opportunities, and they funded a program through Southern Arizona AIDS Foundation, which allowed our clients to have up to 5 months of rental assistance during the pandemic. So that was huge during the pandemic. That was huge help. I also wanted to mention that during the pandemic, we became telehealth services. We became educators of the Hispanic community because we had to teach our clients how to use their phones, right? We had to have computers available for clients that couldn't make it to their medical appointments so that they could see their doctors online, right? And teach them how to do that and support them through that. One of the barriers that we continue to see and we continue to speak about in our community is the housing situation. There are so many barriers that do not allow our people to access housing. We need help. We need to be able to provide these services. Those applications, those HOPWA applications, they're just ridiculous. We need to lower those barriers and thresholds. We need to make these accessible to people. We cannot continue to see people becoming homeless because of the fact that they're not able to access those services because of these ridiculous processes, right? Maybe we can simplify it. And lastly, I want to mention the impact that our program is having. As Chicanos por la Causa is situated in 5 different states, we do impact about 2 million people per year. CPLC just here in Arizona impacts 15,000 individuals on a yearly basis, and that is based on our research and evaluation data. We currently have 95% of the individuals that receive care with us are linked to care. Not 94% are retained in care, and 88% of the individuals that we're currently serving are virally suppressed. So we're very, very proud of that. We are working hard to get those numbers even higher. And I want to thank you so much for your time. I have so many things written down here that I would love to continue to talk about. I talk a lot, but my time is up. So thank you so much.
Thank you. Well, I thought the energy level of the room might drop around lunchtime, but I think you just brought it up. Thank you so much. We'll move on to our next presenter, Sheila Soto. Sheila.
Good afternoon, everyone. Thank you for inviting me to be here today. I'm also really excited to talk about our program at the College of Public Health at the University of Arizona. So the community and engagement programs that I'll be talking about today are 3, which are the mobile health units, the Ventanillas de Salud, and Street Medicine Phoenix. The community engagement programs are coming out of the Office of the Associate Dean of Community Engagement and Outreach. Next slide, please. So our mission with the 3 programs are to prevent disadvantaged populations from relying on the emergency room as their main form of healthcare by assisting with the establishment of routine care and primary care provider. We do this by providing access to health and prevention services and promote healthy lifestyle choices to vulnerable, underserved, rural, and unsheltered communities in Arizona. So the Ventanillas de Salud are the health windows that are located inside of the Mexican consulates in the U.S. Each of the U.S. Mexican consulates have the Ventanillas de Salud, and they're almost like a one-stop shop for community members to come in and get access to health services, and they are referred out to other community resources as well. The U.S.-Mexico Border Health Commission, the Mexico section, funded the creation of 11 mobile health units in the U.S., 2 of which are here in Arizona. One is based in Tucson and one is based in Phoenix. The mobile health unit in Tucson covers all of the southern region of Arizona, including the counties of Graham, Greenlee, Cochise, Santa Cruz, Yuma, Pima, and then we share Pinal County with the Phoenix Mobile Health Unit. The Phoenix Mobile Health Unit serves central and northern Arizona. Street Medicine Phoenix, this is mainly targeting the unsheltered population here in the city of Phoenix. And that one is more of a student-led program that I'll talk about here shortly as well. Next slide, please. So our objectives for the 3 programs, the first one being to provide access to health and prevention services, and we do this via free preventative health services. We refer to federally qualified health centers or other local clinics. As was mentioned all throughout this morning, we know that there are also other social determinants of health that need to be considered and addressed when we are working with our communities. So even though we do have a heavier emphasis on health, we know that there's other aspects that we need to refer our participants to. So whether that's diaper banks, food banks, navigators to help them enroll in health insurance, we work with a lot of our community partners to get our community members enrolled into different programs. We also launch preventative health campaigns and promote healthy lifestyle choices through various means. So we have a large presence in social media. We have Twitter, Facebook, Instagram, and we also have a WhatsApp group for community health workers. We do in-person and virtual workshops with our community members as well. So we do every month at least one Zoom session, and it also goes Facebook Live where we talk about different health issues that the community is telling us that they are interested in. So every week that we have our lunches and charlas, we also invite our community members to send us new topics that they'd want to learn from. Either people from our staff are the ones who teach those charlas, or we ask specialists from other states or our current states or from Mexico to come and do those charlas with us. We also do those workshops and sessions in person. So some of our community partners sometimes ask us if we can talk about a specific topic like chronic diseases, and they'll bring us a group of 50 people and we'll go ahead and talk about those different topics that are requested from us. Next slide. So these are some of the health focuses that we focus on with the 3 programs, both mostly being non-communicable diseases and infectious diseases, as well as behavioral health. On the picture there, you will see a couple of our staff members, and we are in the county of Yuma County. So that is in the southwest region of the state. It borders California. It also borders Sonora, Mexico. So in that particular photo, we are helping farm workers. They just got out of their shift. So in Yuma County, they go by different shifts during the day. We have people that go into work starting at 5 in the morning and they can get out at 1 to 3. And then you have your next shift of people that start from 3 to 9. And then it goes on like that. So this was during middle of the day that we were able to get some of the farm workers that had just gotten out of work. Next slide. These are some of the services that we provide with the mobile health unit, street medicine, and ventanillas de salud. We also partner with other community resources to provide these services. The teams that are in each of these programs do health screenings, which are shown in this first line. So that really is how we are open and able to communicate with our community. That's like our first step into being able to offer all these additional services. And that's really important when it comes to HIV testing, because it helps us try to normalize testing. If we say, good morning, we're here from the University of Arizona. We're here to do free health screenings. These free health screenings include blood pressure, glucose, physical measurements, HIV testing, and COVID vaccinations. Our way of trying to tackle it that way, it also helps destigmatize it, right? So anybody that comes to receive services from the mobile health unit or any of the programs knows that everyone's also receiving these services. They're not being siloed, or it's not a specific table that says that it's only these services being offered. We're offering everything to everyone. Okay, next slide. I think the 3 important models that I want to talk about, which have also been talked about this morning, are these 3 listed right here. Everybody's been talking about partnerships, and I'm really happy about that, because it really is true. No one organization could solve all of these problems. It really takes all of us working together to be able to address the needs in the community. And we're really lucky to have these community partners at the local level and at the state level who also support us. We work together and at a lot of the events. And just makes it really nice for our community members to also see that collaboration that we're having with the partners. And then I want to talk about the service learning component. Because we are an academic institution, we are able to tap into health science students that we have, which also creates a great opportunity for students, because they're able to take what they're learning in class, the curriculum, and actually apply it hands-on in the community. So we have interprofessional groups of students that volunteer with us every semester or during the summer. And it's also a great opportunity for them to experience rural or hard to reach populations, which is something that I know has been brought up during this conference, is that the health professional shortage areas. And we want to expose students to also being willing and open to travel to these areas and seeing the health needs that are also in rural Arizona. And I also want to highlight, for example, in Graham and Greenlee County, as well as Cochise County, those are counties that are more rural that do have a harder time retaining their clinical staff. So with this, via the mobile health unit or via street medicine, we really try to encourage students to consider looking at future opportunities in these areas. Then I also want to talk about the community health workers. So as was mentioned today, we really want our staff to be representative of the communities that we're serving. So I think our community health workers do a really great job about this. And this is why it makes our program so successful, is that they are representative of the communities that we're seeing. We have bilingual, bicultural, multicultural, multilingual staff members who are a part of the communities that we currently are serving. So whether that's in the rural areas, immigrants, part of the LGBTQ community, we try really hard for our staff to be representative of who we are assisting. And it also helps a lot with trust in the community. So if it's already somebody that they know, that they've seen, then it makes it easier for us to, again, have that into the community and trying to help them and connect them to other resources and services. Next slide, please. And I also want to take a moment to highlight our team. Not everybody is pictured here, but just like others, they are also very passionate and really want to make a difference in the community. And they'll also wake up at 1 a.m. if that means being in Yuma at 1 a.m. We work a lot along the border region. So if that means waking up also at 3 a.m. to help the border community, we will be there. And I think that's something really important that I want to highlight, because it takes very special people, very passionate people to be able to make that change and to be there to make a difference. We also have a medical director. We also partner with other programs inside of the University of Arizona to have nurses or PharmDs come out with us, which is really part of the experiential learning as well. They're able to precept our students, again, adding to the workforce that we have. Next slide, please. So how we identify the areas that we're going to serve, we turn a lot to the information that's provided by the local and state health departments. So they have great needs assessments that will highlight the cities or the regions inside the counties that needing help, and as well as the high priority areas. So we know where there's more higher leading causes of death related to heart health or cancer, et cetera. So that's really how we start identifying the communities and the pockets that we need to focus on. We then go in and establish relationships or strengthen those relationships if they're already existing, so that, again, we have an extra support, and it's not just us coming in as outsiders and helping the community. It's somebody that's there that's already helping us build that trust. We host community events, or we partner with other organizations that are already hosting events. Sometimes it is just us with the mobile health unit or a canopy and a table and providing these services, trying to do that our engagement and outreach part of us running into the parking lots of stores or waiting until services are over to try to encourage people to get their health screenings done. We review all of the health screening results with our participants. We do try our best to make individualized health education because we know that everybody has different things going on in their life. So we're trying to make information accessible and flexible to everybody's life. We also have like these little take-home packages or take-home baggies that have a bunch of different information pertaining to the different screenings that we provide. And then something that I also really like is the follow-up that our community health workers do. So with the people that we see, if their results are abnormal, we'll go ahead and do follow-up 1 month after we've seen them. And then we'll do follow-up again 3 additional months later. And that follow-up call, while yes, it's to make sure that they were able to connect to the agency that we refer them to, it also really is a time for us to check in on them and to make sure that they don't need a referral support for another resource. During COVID-19, we had what we called our callback campaign, and it was us calling back everyone that we had served prior to the closures and making sure that they still had either social support or rental assistance, food assistance. So I think this is something that we've been able to maintain even now. Next slide, please. And these are not the most recent infographics, so I apologize for that, but it just shares some of the demographic information of the individuals that we've seen. So the Phoenix Mobile Health Unit started in 2016 and the Mobile Health Unit in Tucson started in 2017. As you can see on the infographics, we do see more females than males. And then our population in Phoenix tends to see more middle age versus the population in Tucson or Southern Arizona. It's an older population. We do tend to see more of those who are uninsured, or if they are insured, it's emergency access. So we know that their coverage is very limited. And then you can see the results of their health screenings. We have yet to include HIV testing results only because we started with the Phoenix Mobile Health Unit in October of last year and in Southern Arizona, March of this year. Next slide, please. Another project that I wanted to quickly talk about was the Mobile Outreach Vaccination and Education Underserved Populations, or the MOVA project. So this one was, again, a collaborative effort to help with the COVID vaccinations. It was during a time where us along the southern region were being requested to help our neighboring country, Sonora, with their vaccination rates. So the mobile health unit here in Phoenix focused and helped a lot in Maricopa, but in the southern region, we did focus a lot of our time along the border. So we were really lucky to have great partners in the state that allowed us to use soon-to-expire vaccine and the various counties that there is in the state, as well as from the Arizona Department of Health Services, that allowed us to use those vaccines before they were to expire. And you can see, like on the bottom right-hand photo, when we first put out the call that we were going to vaccinate, there was over 10,000 people that signed up in Nogales, Sonora, to come get vaccinated at the ports of entry. So it was a great collaborative effort, binational effort, both here in Arizona, but also in Sonora, Mexico. There's just no way that we could have done it without their help. And you can also see a picture on the left top hand side. We had clinicians from both here in Arizona and also in Mexico. So we had some who were retired clinicians. We had preceptors that went out with their students. So really there was, again, no way that we could have done it without the collaboration and partnership of others. If you can go ahead and next slide. And then I just share real quickly some of the numbers. So you can kind of see by county, but at the ports of entry was really where we focused a lot of the time, and it was over 45,000 individuals that we were able to vaccinate during this period. Followed by Maricopa County, again, thanks to the partnerships with Maricopa County Health Department, we were able to vaccinate nearly 20,000 individuals as well. Next slide. And I guess just the only thing I wanted to add was that I think the ports of entry vaccination efforts kind of help remind us that infectious diseases know no borders, right? So we just need to be conscious about that and how that applies to other infectious diseases. Us along the southern Arizona region, we're trying really hard to continue to strengthen our relationships with Sonora, because we know that a lot of the individuals that we're seeing along the border not only live or visit their families here in Arizona or in the U.S., but also travel back. So, and as was mentioned earlier, we know that Mexico in general might suffer from, or usually suffers from, less resources than we do here. So even coming together to see how we can collaborate to find and address some of those issues too. On the top, you'll have the QR codes for our social media pages for the Southern Arizona team. And then the one on the bottom, you have a QR code for the Phoenix team. If any of you are interested in finding more information or want to collaborate on events, we're more than happy to. Yeah, and then that's it. Thank you.
Thank you so much. What great work. And then finally, we'll hear from Dr. Vanek.
So, good afternoon, everyone. First of all, thank you very much for, giving me an opportunity to present the work of the City of Phoenix Fast Track Cities Initiative. So, just to give you some background information about the City of Phoenix, the city of Phoenix actually does not have any jurisdiction over healthcare system in the county at all. So, when they agreed to take on this huge task, the mayor back then, Greg Stanton, he was a good supporter of the HIV community, and we finally convinced him to sign up. So we actually signed up in 2016. So at the beginning, we want to make sure that we include all the stakeholders at the table. So they appointed, ad hoc members, and we have a representative from the state and the county local health department. People from Rand-White Part A and Part B and ADAP program, from HIV Care Directions. They provide case management to people living with HIV in Phoenix. We include all the ASOs in the community. We include Valleywise, which is the only Rand-White clinic in Phoenix. We invited all the local HIV providers to participate. We invited local, especially HIV pharmacists to participate. We invited pharmaceutical companies to participate, and we invited, educational systems like ASU and U of A to participate. So the city of Phoenix actually provides a dedicated staff that they help organize and assist in regular meeting. At the beginning, we had meeting about probably every month, and right now we have a meeting quarterly. All the meetings are public meetings, so anyone can show up. Sometimes we have more than 50 people in a small room, but we receive a lot of community engagement in every meeting. The city of Phoenix doesn't really have any funding for healthcare system, but they are generous enough that the last year they provide an annual budget of about $250,000 that we can use to assist ASOs in the community to host a local HIV event. And they also participate in a lot of events that we have in the community, including AIDS Walk, Pride Festival. The city also assists us in doing social media and campaign. They help us using their platform to talk about our work, talk about the HIV testing event, talk about HIV awareness and stigma. So in terms of structure, the ad hoc member, we have two subcommittees. The first one is the Know Your Status and Eliminating Stigma subcommittee. And the second one is the Virally Suppressed subcommittee. So the first one, the Know Your Status committee, our goal is to increase HIV awareness, HIV testing, and reduce stigma, and also increase PrEP awareness in the community. So with that subcommittee goals, we try to target key community populations. We work closely with all the programs that Grace and Duvia just presented. We talk about, we try to reach out to the Black and Latinx community. We also work with 1 in 10, which is the organization that serves the LGBTQ youth in Maricopa County. We try to go out and increase PrEP and HIV awareness, offer free testing, and also offer PrEP services that they need. The other institutions that we try to reach out is what we call non-traditional institutions. We have been working with all the faith-based organizations in Phoenix. We also reach out to organizations that actually serve people that use drugs in the community. We have 3 or 4 agencies. We try to integrate HIV testing and STI testing with their work. So next, I'm going to talk about the virally suppressed committee. So the virally suppressed subcommittee, we have 3 main goals. The first one is to launch a rapid start program that I'm going to talk about later. The second one is to increase engagement and retention in care for people living with HIV in the community. And the third one is to go out and do a medical detailing to HIV care providers in the community. So for the medical detailing part, we want to go out and talk to healthcare providers in Phoenix about how to integrate HIV care into their routine work. We try to increase HIV testing in the community, and our goal is actually to try to increase PrEP services in the community, because PrEP services is really needed in this community. And, we do not have enough providers to provide PrEP services here. So we try to reach out to all the primary care providers to do that. So when we go out, we talk to them about HIV testing, and we do talk to them about how they can provide PrEP services. And also at the same time, we talk to them about how they can refer patients who are tested positive to our Rapid Start program. So the City of Phoenix, they created this HIV poster thing that we use when we go out to talk to the healthcare providers. One thing about healthcare providers in Phoenix, and actually in general, is that they are afraid to order HIV testing because they don't know what to do with the result. So we are trying to make it easy for them. So we have just 2 phone numbers, one on the left for if they test a patient and turn out they're HIV positive, they can just call that main number and a patient will be linked to our Rapid Start program. On the right, we have the number if they have a patient that get tested and HIV negative and they either need PrEP or PEP services, they can call that line. And our PEP line is actually, it's answered 24/7. So anyone can just, any providers that they can call and refer patients that need PrEP or PEP services. So last year, there are, I think, 5 or 6 FQHC in Maricopa that got awarded for PrEP services. And those FQHC actually do not have any HIV or PrEP providers. So we were able to go out and train all the providers at the FQHC to do PrEP services. And also, if they don't want to take care of HIV patients, they can refer patients to our Rapid Start program. So I'm going to talk about our Rapid Start program. Our program has an acronym of is called START, which is abbreviation for a State of Arizona Rapid Treatment. And this was launched in September of 2018. And our goal is to link either newly diagnosed HIV patients or patients that fell out of care and they are re-engaging in care. And we try to link them to care within 0 to 5 days. I want to share with you some of the lessons we learned from the Rapid Start program. So first of all, it's really difficult to launch a program, a citywide Rapid Start program. Because we have to link all the HIV testing site to the HIV clinics in the county. And, we have to involve with many institutions, many organizations, and it is very difficult to get them to change the way they used to practice, especially some of the, public health institutions. They have been doing the same thing for the past 20, 25 years, and it's just almost impossible to change. And I still remember the day that John Shapiro and we were scratching our head because we didn't know what to do. And luckily, we have a City of Phoenix to be a support. When we cannot find a solution, we ask for the City of Phoenix to actually invite, that institution or organization to come and meet us at the mayor office and have an open table talking and discuss about everything, and it works. We get stuff done. We're trying to convince people to change their internal program, internal workflow, and they agree. And so at the beginning, we only had 3 rapid start clinics in Maricopa County, and now we grew to 11 clinics throughout the Maricopa County. Another lesson that we learned is that, rapid start is not new, and you don't have to reinvent all the wheel again. So you can ask for technical assistance from other cities. So at the beginning, we asked San Francisco Public Health Department to come and talk about their programs and help us set up a program. And we had a one-day meeting with them, one-day training, and we copy a lot of stuff from San Francisco, and so that really helps us a lot. Another thing that we have to think about when we launch the program is that how we can see patients who are uninsured within the same day. So we try to streamline our application process for Ryan White and ADAP program, and we cut back some of the red tape that some of the documentations that you might need it upfront to do the application. So right now we can enroll patients within 4 hours. So the patients can actually be seen possible within that same day. Another hurdle that we run into is that how can we link testing sites to the HIV clinic. So we created at the beginning our Rapid Start Navigator. And so we have a single point of contact between testing sites and the Rapid Start clinics. So the initially our Rapid Start Navigators is a case manager at HIV Care Directions, and they help either refer patients who are insured to the appropriate clinics or enroll patients who are uninsured and refer them to the Ryan White clinic. The next thing is, we did not have the best way to communicate between all the stakeholders. There's the clinics, the navigators, case manager, ADAP, testing sites. So luckily, ADHS has provided some funding for our red phone system. Actually, at the beginning, we called that a bat phones. So this is basically it is a cell phone that can only be used for rapid start. So if the phone rings, we know that we have rapid start patients. So this phone is actually located at all the major HIV testing sites, at the county STD clinic, at the Care Directions, who does case management, RAMSO, who manage ADAP, and we just added Dignity Health emergency room because they just launched the opt-out testing in their ER, so they can refer patients to our Rapid Start program. And this bat phone or red phones is actually funded by our Ryan White Part B program. And last year, we added a local HIV community lines, so providers can call, we have another separate phone number, and this phone will ring at the Maricopa County STD clinic. The HIV CDI will answer and refer patients out to appropriate agencies or clinic. We have a list of all the insurance that are accepted at each clinic at the Maricopa County, so they can refer patients out immediately. The next thing that we had to come up is that how can we track the success or of our program. So ADHS partnered with Tri-Young to develop a rapid start careware, and this is pretty much like careware that they used for a lot of the HIV clinic. So with that, we can track progression and retention in care of patients that are enrolled in our Rapid Start program. So our Rapid Start program has been ongoing for 5-6 years now. So I want to share with you some of the result. So before we have a Rapid Start program, it took about 30 days to link patient from diagnosis to care. And right now in 2021, we are down to 4 days. And for the time from diagnosis to viral suppression, before we launched the Rapid Start program, that took about 129 days. And right now we get patients to undetectable within 38 days. So there are a lot more to be done with a Rapid Start program. We still have to go out to the community and talk more about that. A lot of the providers still don't know about our program. That's a work in progress. But, with the success of our system in linkage, newly diagnosed patient to care, we are now copying it to other programs. So we just launched our Rapid PrEP program. Maricopa County STD Clinic, actually, they are the largest HIV and STI testing site in the county, but they did not offer PrEP services. So we use the same system. We use the same red phone to refer patients out to all the PrEP clinics in the community, so the patient can be start on PrEP as soon as possible. And also, we are also looking into using the same system to launch a rapid Hep C treatment program. So we can link patients who are tested for hepatitis C to treatment right away. So before I finish, I would like to recognize two City of Phoenix staff, Sergio Gomez, who's a strategic initiative manager, and Tammy Rivera, a strategic initiative specialist. They work really hard, and without them, we could not have done our work. But I think in summary, I want to tell you that before we had the Fast Track Cities program, we have multiple agencies in the community doing work in parallel. They all work independently without talking to each other. And now with the Fast Track Cities program, we are working together and collaborate our work. I have talked to many other cities and that maybe sign up for a fast track. And one of the things that I hear a lot from other cities is that there are so many agencies, many institutions, many ASOs that they are fighting for the same grant, same funding. So there are some competitiveness in there, and they just couldn't get the work done. And I think, we are fortunate for the City of Phoenix to help and putting everyone together on the same track. So we instead of working and competing each other, we are working together towards the same goal. So I think that's the end of my talk. So thank you very much.
Thank you very much, Dr. Vanek. And I'll open the floor to questions from PACHA or our guests. And we'll start with you, Laura.
Thank you. I just have just a few questions. My first question is just more of curiosity. How do you protect patient data that is collected at mobile units? I'll just ask all my questions and then whoever needs to answer. And curious as to whether mobile units have set days and times that they visit communities. Or are they done like one mobile visit at a time? And then my last question is, what protocols do you use when you enter or do work on reservations? So, and thank you for your work with tribes.
I can answer that question. When it comes to our mobile units and securing PHI, we normally have 2 mobile units that operate in Arizona. And when it comes to our events, we normally staff each event with 1 unit per event. So with PHI, we have all program specialists that do those outreach events. They have PHI lockboxes, and we do have a very rigorous policy when it comes to transporting PHI. With going to rural areas, we do have a lot of overnight trips. So we do have a standard of just practice when it comes to PHI security to not only have it within your lockbox, but also to secure it in a very, it's actually very rigorous to secure it in a space that's also locked, something like a cabinet or a bathroom to make sure that PHI doesn't get disclosed or someone doesn't access it. When it comes to EMR security, we actually have our EMR system, eClinical works. Majority of our program specialists do go out with their computers, and with their computers is very rigorous encryption to be able to protect that information. When it comes to reservations, we do not do we allow data sovereignty. So we do not ask if individuals do not want their health information accessed or shared. We want to make sure that we do protect that individual's right to their health information as well. So with that being said, a lot of our practices is very much patient focused. We do want to be able to provide the best amount of care. However, we want to ensure the patient feels comfortable accessing our services as well.
Just a quick follow-up. So I was curious as to whether you have to get approval from the tribal councils before you go into the communities.
Yes. Majority of our outreach events that are on tribal lands, we do have to get permission in order to be there. Allison, Shirley, and myself, and also a few of our CAN leaders have been working together to start having more conversations about going on tribal lands, such as recently we went to Navajo Pride. We had to talk with the organizer of that event and tribal leaders to be able to secure being at that event. So majority of the times we do get to have conversations about it.
And then I didn't see whose cards went up first, but we have Justin and Leo. I'll let you shank fight for who'd like to go first.
We're lovers, not fighters. So I have a few questions. And first, just thank you all. I continue to be inspired by the work that's being done here. So thank you all for sharing. 2 questions for Grace, and then 1 question for Duvia. So Grace, I wanted to know how treatment is coordinated for patients who have positive tests. When your units go out, like, do you go back out to provide treatment, or is it all through mail order? And then my other question for you is, could you share more about the Gilead and ViiV partnerships that you mentioned with other communities of color? And then Duvia, my question for you is around 340B and rental assistance. When I heard that, I just wanted to hear more about, because it sounds pretty innovative. Thank you.
When it comes to treatment, in particular with our mobile unit events, so when the team goes out and individuals do test active for, let's say, hepatitis C or HIV, we are able to connect them to care, depending on the area, is most in particular what our procedure is. So if it is local here in Phoenix, we're able to connect them to our clinic and they're able to see our provider within just hour span. We do also have a clinical team, and on that clinical team, we have a patient care coordinator, and she does the job of making sure that individual reaches the clinic. So we do provide Uber Health for any individuals. Let's say if we're about 20 minutes out from our clinic or 45 minutes out from our clinic, we're able to Uber help that individual in to be able to get started with medication as soon as possible, or we're able to set them up with the appointment that works for them within the next week or however many days they need. So when it comes to that local aspect, that's kind of our treatment service line. When it comes to a rural aspect, a lot of our community engagement with partnerships is our biggest because we want to be able to provide the best services that we can. So if that individual can't reach our Phoenix client services when it comes to telehealth, we're able to connect them with an organization that's within their area that works best for them to stay adherent to medication and also to have a location as close to them as possible. So when we are out in those rural areas with our mobile unit, we have community partners that we've reached out to create connections to say, if we have any individuals that do test positive, we're able to refer them to your clinic. And we do keep a resource binder on board of our mobile units that has a list of all the community partners in that area for that client to have access to care. But if they're local, we're able to do our mail meds team, they're our pharmaceutical team, they're able to mail them off as soon as that individual touches our clinic or wherever they're at when it comes to telehealth. If it's more rural, our mail meds team doesn't go rural at this time, but we do have the access of community partners and also referral resources that we use. And for your second question, I'm so sorry, Leo, you may have to ask me your second question again. I apologize.
I just wanted to hear more about the Gilead and ViiV partnerships that you mentioned.
Yes. So with the Community Health Initiative, a lot of the planning that went into it from the team that I am on is we wanted to ensure that not only are we just going out to test and then after that, just kind of leaving, we want to make sure that we make a lasting impact and we create a long-term partnership. So with that being said, I reached out to Gilead and ViiV to be able to build more key partnership with community liaisons that already do the work of the community to start bridging the gap between communities of color and also community-based organizations. And Gilead and ViiV already do a wonderful job at building programs like the HBCU Roadshow that Gilead is doing. And with ViiV, they also have a project that focuses most specifically on Black women. So I knew that was potentially an opportunity for the funders to be able to start building more projects with more ASOs and other agencies that are willing to do the work and go out to the community. So the first step that I took was to start talking with the Gilead community liaisons, start talking with the ViiV reps and ViiV liaisons to start building that relationship and that dynamic to know how can we go out and provide services? Can we start increasing when it comes to our mobile unit events? Could we start putting on educational program? Could we have you all sponsor dinner programs where we bring in community organizations to learn more about PrEP and HIV medication? So that's how we built the relationship when it came to Gilead and ViiV.
Thank you.
And it's been very exciting too.
Yeah, thank you.
Thank you.
And then for my part of the question, our 340B program is something that we developed a couple years ago. We're very fortunate that we are licensed under HRSA for a program for individuals that are living with HIV, and then also for our prevention side of the services. So both patients under prevention, patients that are receiving PrEP and PEP navigation can qualify for rental assistance through our 340B program, and also for patients that are living with HIV. We developed an application at Chicanos por la Causa. One of the things that and we also did a needs assessment. The highest need that we continue to see for our population that we serve is housing assistance. A lot of times these are individuals that do not qualify for HOPWA. They've been waiting on HOPWA applications for 3 months that in the end get rejected. So these are people that are about to lose their home, and we are a last resource for them. These are people that have been turned away from the city of Phoenix because they don't qualify for those programs. People that have been, so we do our due diligence in ensuring that people do not qualify for other programs. But we do have a large population of people that do not qualify for those programs, unfortunately. So as a last resource, luckily under HRSA, one of the allowable activities is for us to be able to develop these programs that give back to our patients. And we decided at Chicanos por la Causa Luces, this is something that is a great need. It's the greatest need in the community that we're seeing currently. For the people we serve, we developed the program, we developed an application process. Our case managers and our PrEP navigators complete those application processes, and then they get approved for a one-time rental assistance up to $2,000. So not only do we offer the copay assistance for individuals, but we are also able to offer that one-time rental when we are their last resource, which a lot of times we are.
Thank you.
And then, do we have time for Justin? I'm sorry, we don't have time. We don't have time for your question. However, I will encourage you to come up and talk to any of our panelists afterwards to do that.
I encourage you.
I want, if I could, I just want to take 1 minute. First, I wanted to share that our local response to the HIV epidemic I believe CPLC was involved in that along with Concilio Latino de Salud way back in the day when they hosted our first AIDS walk here in Phoenix, which was not the typical fundraising event that you might think of today. It was actually a group of individuals that marched coffins through the community to demonstrate the impact that HIV was having on the Hispanic community and the need for work to be done locally. The second thing is I'd really like to thank former Mayor Greg Stanton, City of Phoenix Mayor Greg Stanton, and our current Mayor, Kate Gallego, for not only founding the Fast Track Cities Commission, but also keeping it alive and actually funding it. That $250,000 that Dr. Vanek shared has really been instrumental in the community because it is completely unrestricted. It's been distributed through microgrants and other grants to county entities and community-based organizations, and it is really, I think, demonstrated not only with the work that our state and county and community has done, but we have this really great relationship between our public health programs, our community agencies, our private partnerships that you just described, and our city, county, and state governments. And I think that is the greatest innovation that we could share with you today. So thank you, panelists. It's wonderful to be able to share you with the nation, and I appreciate your time.
And I ditto that. Thank you. So we are going to next move to lunch. Those of you on PACHA who have paid for lunch, we're going to be meeting in the same place we did yesterday on the other sort of wing. For those of you who are lunch on your own, there are many sort of places in the very immediate vicinity. We've been frequenting some of them in the evening and enjoying those. So we invite you to lunch there. For those who are cold, we have been continuing to turn up the heat and asking for that. So we're hoping it's going to be a little warmer after lunch. It seems like it starts out fine in the first morning and then gets increasingly chilly. We will come back at 1:45. So we will compress the agenda a bit. So 1:45, we'll start back up. Thank you.
Produced by the U.S. Department of Health and Human Services.